Good evening, delegates. Thank you for joining Shield Connect today. Today we have Dr. Gurujala Shailaja Ajit. Ma'am is a consultant at Yashoda and Rainbow Hospital, Hyderabad. And ma'am is going to take topic dyslipidemia in PCOS. And before we start with the session, let me give a little introduction of our page also. This is our page shieldconnect.in where you can find different sections are available. First section is the blog section where you can find different blogs written by the eminent speakers who are connected with Shield Connect. Then we have webinar section where you can go through our webinars going on. So when you click on today's webinar, you will find the page of the webinars going on and you can post your queries in this comment section. So we can have a Q&A session at the end of the webinar with our speaker for the day. Then we also have different pages like PCOS, menopause, GDM awareness pages. So if you click on any one of the pages, you will find different videos regarding to respective topic. And we also have specialty pages. And you can also go through the key opinion leaders profile in detail on our page who are connected with Shield Connect. So this is our page Shield Connect, and now let me give a quick introduction of our speaker, Dr. Shailaja Ajit. Ma'am is consultant at Yashoda in Rainbow Hospital. Ma'am was professor and HOD in Pratima Institute of Medical Science, Karimnagar, as well as a DME and principal and HOD of Osmania Medical College. Ma'am is trained in infertility in Bourne Hall in UK and also trained in laparoscopic surgery in Germany. Ma'am was past vice president in AICOG 2011. So ma'am, I welcome you on our platform for today's session and I will hand over the session to you, ma'am. Thank you, ma'am.
Thank you, She'll Connect, for those kind words. And I thank Mr. Pavan also for asking me, for inviting me to, I hope I'm audible.
Yes, ma'am.
For inviting me to give a small talk on PCOS. And I thank my heartful thanks to all the consultants who are listening to my talk. So everybody knows about everything about PCOS. That's what I thought. But then when I started reading up, I realized there's so much more to it than what we know. And PCOS has changed 360 degrees, total change from the time we realized, from the time I was a postgraduate, that is in 1978 till today. So there, every step of the change, I have been there, I have seen, and I have treated the cases. And earlier it was very rare. It was called Steen-Leventhal syndrome. And it was very rare. Hardly we used to see one case in 6 months or so where the woman had excessive hair and large pearly white ovaries. There was no scan. There was no laparoscope those days. So we just with the history and hyperandrogenism. That was the main feature those days, where we diagnosed that she had anovulation and excessive hirsutism, hair. So then the treatment was only vaginal sections. We did a lot of vaginal sections, many conceived, and then gradually it changed. Then with the onset of ultrasound, all the radiologists were making the diagnosis for us whenever they see a PCOS morphology. Even today, most of the radiologists says PCOS, and these patients get so worried, and the patients' mothers get so worried, they come running to us and they say, no, my daughter has PCOD. See, just a morphology, appearance, the radiologists are not the people who are going to diagnose PCOS. It is you, the gynecologist, who has to say whether she has PCOS or not. And it does not depend on the morphology of the ovaries. She has to have the basic criteria to say she has the syndrome is she has to have hyperandrogenism. And it can be proven clinically. Clinical hyperandrogenism is how? Oligomenorrhea. She has scanty periods or amenorrhea. And naturally, once she has amenorrhea, she has anovulation. And of course, she may have polycystic ovaries morphology or not. But she must have hyperandrogenism. Excessive hair, hyper and oligoamenorrhea or amenorrhea, scanty periods. She may be obese, she may be lean, and she may or may not have the ovarian malformation. So it is the most common, it's an endocrine disorder. It is not a disease of the ovaries and just she has bubbles on the ovaries and you remove the bubbles or you burst the bubbles, her disease is gone. No, this is one problem which is lifelong. There is no cure. We can only suppress. And this suppression can occur major due to lifestyle changes, exercise and diet. And if we diagnose this condition much before puberty, when the girl is 9, 10, before she attains puberty, you can totally cure her. But after puberty, it is only suppression of the hormonal imbalance or suppression of the hyperandrogenism. So when the girls come accompanying their mother, you see if they are obese, if they have those linea nigra and the neck, then you know most probably she's going in for PCOS. Please tell the mother, see your daughter has this problem. She can have this problem later on. Let her play, actual play, not just sitting and using the computer and computer games. Physical activity. Whether she loses weight or not is immaterial, but she has to have 1 hour of physical playing activity. So 3 to 10% of reproductive age group, here it can occur in the adolescents, reproductive age group, and also in the perimenopausal and postmenopausal women also. And it is one of the major causes of infertility because there is anovulation. So 25 to 30% of infertile women have PCOS. And in India, it is about 117 million patients. Is because mainly because of a change in our eating habits and sedentary lifestyle. And 1 in every 5 women have so many. It's just, and it is increasing day by day. All of you know that. So the pathogenesis, we know there should be some genetic predisposition. If she was, you asked that girl, the mother of the girl, whether she was a low birth weight. So if she was a low birth weight or the lady, the mother had GDM in pregnancy, those are the genetic expression that this girl can have PCOS as she grows up, which will lead to genetic predisposition to excessive androgens because of GDM, or she can have polycystic ovarian morphology, and because of that there may be excessive androgens and LH levels will rise. There is a steady fixed rise of LH. It's not the wavy pattern, but it's a fixed rise. And then this testosterone is androgen, that is the male hormone. So they tend to change into a male. What are the changes in the male? The first thing is they don't have periods. So you have irregular periods, then amenorrhea, and then scanty bleeding, and finally amenorrhea. And then because after that anovulation, irregular periods, then you have excessive hair, especially on the upper lip, chin, and on the straight line on the from the umbilicus to the mons, you have hair. So the male distribution of hair, and this testosterone again causes increased insulin resistance. That is the next one. It is a syndrome which there is, most of them have increased insulin resistance. And then these insulin levels increase, and then from the liver you have lowered SHBG. Then you have increased insulin resistance, which leads to excessive free fatty acids, leading to dyslipidemia, high triglycerides. So all these girls, when they have PCOS, you please in the first instance itself, instead of doing all your insulin resistance or anything, get her AMH done, because now they think it is a inflammatory response. It's a partial inflammatory response. So cytokines and LH and TH1 cytokines are also rising. So it is an inflammatory response. It's an endocrine disease also. And it also, because it's an endocrine disease, you have insulin resistance. So here in polycystic, you have, it may be a congenital predisposing problem may be there, and then postnatal provocation also can be there. So congenital is, they have, maybe the mother had GDM, mother has hyperandrogenism, and this child was IUGR, small for dates. So all these, that is again heritable diseases, congenital virilization, and IUGR, so that is or less nutrition. Disturbed fetal nutrition are all congenital factors. Then insulin resistance, hyperinsulinemia, metabolic syndrome, postnatal obesity, and obesity when she has puberty, and irregular periods after the before 16 years. If she has one period in 2 months, 3 months, please don't bother. Just ask her to have a good play well. Ask her to have a good 1 hour of exercise, either walking, skipping, or jogging. But from the 17th year, if she has periods more than once in 3 months, these are the girls who are going to have PCOS. And then the phenotype is, of course, all of us know commonly they are overweight, but even the lean women also have PCOS. So the diet and postnatal also, they can become, for the first pregnancy they didn't have, they can have PCOS after the first pregnancy, after the first delivery. So you can have PCOS phenotype in pregnancy, in utero, adrenarche, adolescence, or adulthood. So you have insulin increased resistance, ovarian factors, androgen excess. It is a must. So hyperandrogenism is a must. Then then you have excessive fat storage, hormone exposure, exercise. If she has no exercise and activity, yes, environmental, inflammatory. So now we think, just like Zinda Talismat is used for every disease, now we have come to a stage where we say every disease, it may be inflammatory in nature, because all the immunological factors are disturbed and your cytokines, the bad cytokines, increase. So these are all the causes which can lead to PCOS. So fetal programming, when there are small fodates, IUGR, and in pre-puberty, if they have excess weight, they do not have any play time while they are growing up as girls. They're always sitting in front of their iPad or phone or a computer. So they don't have any play at all. These girls who do not play, they put on more weight, and these are the ones who are going to have PCOS later on, especially if they have a genetic predisposition. And they have premature adrenarche, premature puberty, young girls where they menstruate by the time they're 8, 9. And then, of course, in adolescence, because of your junk food eating and your fizzy drinks, no exercise, always they are working in these AC environments where the company supplies them high fat food, which is full of oil and fatty acids. So here and then night shifts, basically night shifts. So they have irregular menstruation because their biological clock is altered, and they go on taking they don't want to have menstruation, or they take IPIL, or they take so many kinds of drugs. They want to postpone every month, they want to postpone their periods, they're athletes. And then once in the adulthood, reproductive age group, they already have obesity, carbohydrate intolerance, that is insulin resistance. And once you have insulin resistance, you have dyslipidemia because the triglycerides are high. And all these cause infertility. Once you treat infertility, they are again high risk during pregnancy because they can develop GDM, and GDM you have hypertension, PIH 3 times more. And then again you have IUGR, and that baby again becomes PCOS. And later on in life, these women, they become very early, 35, 36 years, they become diabetic, or they can have carcinomas, cardiovascular CAD, right? Hypertension, endometrial carcinoma, malignancies, breast cancer, and most commonly, because they have dyslipidemia, they can have CAD and strokes very early, maybe 40, 45, they can have CAD. So early menarche in adolescence, then oligomenorrhea, and then acne, severe acne. And then, of course, late adolescence again is hirsutism, and hyperandrogenism, I told you, is the hallmark of PCOD. And you don't have to do any of these DHEAS or fasting insulin, just clinical. There's no need for biochemical, except a little LH, because to know if it is LH and AMH if she wants fertility. Otherwise, LH, and you will know whether it is CRP you do, she will know it is inflammatory. And perimenopausal, postmenopausal, they have dyslipidemias, more prone for CAD. So hyperandrogenism, insulin resistance, abnormal lipid, naturally it causes abnormal lipid metabolism. All of us know the action of insulin, but the action of insulin on the adipose tissue is, it is anti-lipolysis in, uh, it, uh, it is anti-lipolytic action on the adipose tissue. So this anti-lipolysis, what does it cause? It releases few free fatty acids. And then it also stimulates the glucogenesis, so that more of glucose is metabolized by, it is taken up by the muscle structures. And once you do not have, you have excess free fatty acids, if there is a lot of adipose tissue, then free fatty acids are increased. When free fatty acids are increased, triglycerides are increased. So this free fatty acids, what they cause, once free fatty acids increase, triglycerides increase, there is increased insulin resistance. It's a vicious cycle. So dyslipidemia, because of obesity, they can have dyslipidemia. Once they have dyslipidemia, again, the fatty acids are stored in the body, and there is hypertension. And also because of obesity, you have obstructive sleep apnea, abnormal lipid metabolism. And then because of this action of this hyperandrogenism is, the follicles are not, the number and the quality of the follicles, the damaged follicles are there, immature follicles, and also the quality of the follicles are bad. Impaired potential for the development of the ovum, and even the endometrial receptors are also poor. So all the levels there is damage and disease. So the metabolic syndrome is, all of us know, it is central obesity, hypertension, atherogenic dyslipidemia. Once there is dyslipidemia, the plaques, the atherogenic plaques are all in the vessels, and because the vessels are blocked, they are more prone. And these triglycerides, we have a large number, they break down into free fatty acids and also into the apolipoproteins and the LDL, HDL, depending upon the density of these fatty acids. You have LDL1, LDL2, HDL, depending upon the very low density, high density, depending upon the density, they are classified. And very low density will, LDL, very low density LDL, if they are high, it will block the vessels, and it will very high risk for your cardiovascular accidents. And if it, and because where these low density lipoproteins increased fatty acid, what happens is the very HDL becomes nanoparticles. They destroy the, there is lysis of the HDL, and they become very small particles. And because of their very nanoparticles, there is increased clearance by the kidney, and hence their HDL also is decreased more and more. That's what happens mostly. So adipokine tissue obstructive, when there is obesity, you have sleep apnea, obstructive sleep apnea, and most of these women who are obese in PCOS, and it is one of the causes of sudden cardiac arrest and CAD, insulin resistance, then androgen-mediated lipolysis, genetic factors. All these are there because of PCOS and dyslipidemia, which will not only cause infertility, is one of the minor endpoints of PCOS, but the major is the life of the woman also is at risk, jeopardy, because she is at high risk for CAD, strokes, and sudden cardiac arrest. So dyslipidemia, how does it occur? I have already told you that there is increased insulin resistance, and then because of increased insulin resistance, you have oxidative ROS is high, and these ROS, these are the abnormalities which are observed in women, and high triglycerides. And high triglycerides, you have this HDL, I told you, HDLC and LDL. LDL is increased. HDL is good. LDL is a bad cholesterol. So HDL is decreased because it is broken down into smaller particles. So increased clearance by the kidney. There is less production and increased clearance. So all the more less. And then these low density lipoproteins are also increased because of the triglycerides, the free fatty acids, and the triglycerides break down into LDL. And they're higher concentration. And they are bad. These are high risk. And when do you do? We have to do a fasting lipid profile in all these women who have PCOS in the reproductive age group. And if the cholesterol is high and the triglycerides are high, you have to repeat the triglyceride level postprandial. Postprandial, towards after postprandial, if still the triglycerides are high, these women are at a very high risk for CAD. It's not only the fasting triglyceride level, you have to do a 2-hour postprandial triglyceride once the fasting levels are high. And once you go to a cardiologist, they have different apolipoprotein 1, 2, all these, and LDL1, LDL2, LDLA to E, all these uh, different subtypes of LDL and HDL, they do it. So 50% of women with PCOS, they have the risk of diabetes mellitus, and even 70% of women with PCOS, even if they are lean, they can have dyslipidemia, because lean women have more insulin resistance, and when they have more insulin resistance, more hyperandrogenism, they are difficult to treat medically. Most of them, if they failure to conceive and failure with your regular drugs, so they may need LEOS, they may need a laparoscopic drilling. So the lean PCOS women are difficult to treat. The obese women, it is because of excess fatty tissue, and once they lose the adipose tissue, it's easier to treat them. They're easier to treat than the lean women. Lean women have higher insulin resistance than the obese women. So they have reported that HDL is decreased, I told you, to decrease production and increased clearance by the kidney. So there is the proportion of insulin resistance was high in obese women. It can also be there in lean, but it is more higher in obese women. And dyslipidemia is also found where there is central fat. That's now we say PCOS syndrome, when you measure the waist circumference rather than looking at the other biochemical. You just look at their waist circumference. More than 85 centimeters, they are more prone for dyslipidemia, and they have higher insulin resistance. So we are now going back to the clinical parameters rather than the biochemical and artificial intelligence telling you about HDL 1, 2, 3, 4 or HDL A to E. So you have to be aware clinically about what are the clinical parameters, which you can just look at the patient, and if you examine the patient properly, you will know. Because I'm of the old school who still believe in that doctors are clinicians rather than diagnostics. So you do depend on diagnostics to only say that you have diagnosed clinically. You have to confirm your diagnosis. Right? So the subcutaneous abdominal adipose lipids, they protect against IR in humans, but the subcutaneous fat protects, but the intra-abdominal fat is in insulin resistance increases. That's why we look at the circumference. And then when there is this dysfunction of the intra-abdominal fat, you have increased free acids uptake in the circulation. So hyperandrogenism is the vital feature of PCOS. As I've been telling you, if you have hyperandrogenism, she is definitely PCOD syndrome. And all of them found most of them have dyslipidemia. This indicates that androgen is bad for lipid metabolism, and dyslipidemia does not directly involve in the metabolism in PCOS, but because of dyslipidemia, they are more prone for increased insulin resistance and CAD. Risk of CAD is more. So even in lean PCOS, you have dyslipidemia because of the high IR and because of increased intra-abdominal fat. It may not be subcutaneous, but they may be intra-abdominal adipose tissue. And they present this adipose tissue dysfunction, I already told you, and the fat distribution. So reduce apolipoproteins. So these apolipoproteins, 1, 2, A1, A2, all these are there, the sub classifications. So A1 levels have been observed in the PCOS patients. A1 has knocked down and reduced the number of transcripts of enzymes in the human ovarian granulosa cell line. And that is, these are the markers KGN and P13K. All these are produced in excess when there is free fatty acids. And when these enzyme levels also increase in dyslipidemia. So CYP19 expression is reduced in dyslipidemia, and hyperandrogenism, and high testosterone DHEAS is raised in PCOS that occurs much later. Dyslipidemia is one of the earliest changes of hyperandrogenism, and high testosterone is the later changes. Oxidative stress, I told you again, it is inflammatory. Why is it inflammatory? Because of increased ROS, oxidative stress. So it is a slow, adipose tissue itself it produces more of pro-inflammatory cytokines. The Th1 and the Th2 cytokines are increased in the adipose tissue, and they secrete angiotensin 2, which stimulates the NADPH oxidase activity. And this NADPH oxidase is a major route of production of in the adipocytes. In addition, the increased free fatty acids again stimulates the nicotinic acid expression of the ROS generation. So this NADPH, which causes breakdown of triglycerides, it is one of the enzymes which causes the breakdown of more of triglycerides, and it leads to more of this enzyme is more, so ROS is more. Yeah, then oxidative stress, I told you again, it is it is inflammatory. So sometimes anti-inflammatory action, these which we are using now, some of the drugs, they reduce the inflammatory effects. That is the reason why we are using more of this antioxidants. So lipid lowering therapy was found to be effective in lowering so dyslipidemia causes ROS. So if you reduce dyslipidemia, the inflammatory markers are less, they become less. Anovulation has been, of course, it is related to dyslipidemia, and obesity leads to dyslipidemia, all of you know, and free fatty acids. So dyslipidemia and ovulation, that lecithin-like oxy-LDL receptors, they have a differentiation with the different enzymes which are there, and they dependent to LDL dependent activation occurs, and these receptors can result apoptosis of the granulosa cells. So there is apoptosis of the granulosa cells, they are damaged because of these enzymes. And in addition, the abdominal obesity itself stimulates adrenal androgen production. Again, androgens are high. Again, triglycerides are high. Again, free fatty acids are high. So again, you have higher levels of ROS. Sorry. So lipids will cause already there's anovulation, and anovulation worsens when there is dyslipidemia. And remember, it is one of the earliest signs of PCOD or PCOS syndrome. So there is increased level of glycerol, lipid region, cholesterol, and LDL also have been in the follicular fluids in the granulosa cell fluids also. They have found all these levels are increased, and these suggest that the dyslipidemia influences the improper growth of the granulosa follicles. So this is the same thing what I told you in a pictorial form. Dyslipidemia, you have monocyte counts, HDL is increased, free fatty acids are increased, which causes increased inflammatory cytokines. And once there is inflammation, it again increases the PCOS. Then the NADPH enzyme, which is there, which releases a lot of reactive oxygen, oxidative stress, ROS, which again in turn increases insulin resistance, which is found in PCOS. Then cholesterol ester uptake, that apolipoprotein A1, and all these are all the enzymes which are act on this uptake, which are deranged, which leads to excessive fatty acids and PCOS. Then there is mitochondrial dysfunction because of the OX-LDL level, the different, I told you, the subclassification of LDL. Again, ROS is increased. There is follicular atresia, damaged follicles, and ovarian damage leading to anovulation. So in PCOS, you have inflammation, which increases PCOS, Again, it has anovulation because of dyslipidemia. Again, there will be more of, say, PCOS syndrome. This NADPH enzyme is nicotinamide adenosine dinucleotide phosphorylase oxidase enzyme. Hyperandrogenism. So here, the most important thing is here, hyperandrogenism. This hyperandrogenism is the most important, which will, then there is this increased insulin resistance and anovulation, inflammation. All of them are factors for PCOS, and all these are raised in PCOS syndrome, which leads to all the other problems which occur in PCOS. So it's not only infertility, there's so much more than infertility to PCOS. So the lipid lowering drugs. Now we know that dyslipidemia is there right from the earliest stage of PCOS. So you can give statins, you can give nicotinic acid, you can give antioxidants because of the ROS, and you can give statins, and so many other drugs are there which are still, they're thinking of the various drugs, whether to give statins or not. With statins is not yet proved in PCOS that it improves hyperandrogenism, but we are still not using it in very liberally in PCOS with dyslipidemia. But if you have proven dyslipidemia, if your postprandial triglycerides are high in adolescent and reproductive age group, you first have to give statins, reduce the triglycerides with your, lifestyle modifications, and then give your antioxidants. So they improve dyslipidemia, they improve hormonal profiles, and now we are using curcumin, which is again an anti-inflammatory, which will in PCOS because of the inflammatory cytokines are more. So statins will reduce oxidative stress, and it also improves the endothelial dysfunction and also reduces cardiovascular disorders and fecal hyperplasia. Insulin resistance also will be reduced by statins. And if you can prove that she has severe dyslipidemia, please use statins. Statins are commonly used to treat to reduce inflammation. I've already told you, and how they help also, all of you know. And after treatment with atorvastatin or which we use as statins, vitamin D also helps to reduce the ROS. So all these women with PCOS, you do your vitamin E, you give vitamin E and you estimate vitamin D. And D, we have to give 60K. Now, NIMS have done a study where they say we have to give vitamin D 60K daily for 10 days and then give once a month for these women with PCOS. Excuse me. Then statins, they reduce, of course, they are helpful before you start ovulation induction. Please give them statins. And they also improve lipid abnormalities, inflammation, oxidation, the stress. Simvastatin, lorvastatin, these are the common statins. Simvastatin can improve menstrual cycle activity, hirsutism, acne, ovarian stimulus, decrease ovarian volume also. And it can also inhibit the proliferation of follicular mesenchymal cells and reduce the expression of the production of androgen. It reduces the production of androgen. So simvastatin is useful, and it also reduces the hyperhomocysteine. Then omega-3 polyunsaturated fatty acids are also very, very important. They improve lipid metabolism, and they prevent in the adults, that is in the reproductive age group, they prevent CAD, so it is better. If you find PCOS and dyslipidemia in the adulthood, please put them on omega-3 fatty acids, perimenopausal age group and menopausal age group. Omega-3 fatty acids are, polyunsaturated fatty acids are important drugs to reduce the dyslipidemia. So they are naturally, they activate the peroxisome proliferator activated receptors, and they reduce the dyslipidemia. They're very good, and they reduce the free fatty acid storage. After supplementation with omega-3 fatty acids for 12 weeks, the expression was significantly reduced and LDL receptors were reduced. And also they have found that even the protein kinases, which I told you, the enzymes, and these are the predictors of lipidemia, all these are also the pathway enzymes. Oxidative stress are all reduced in PCOS women. So please use, especially not in adolescence, but in adulthood, in the reproductive age group, they should be on omega-3 fatty acids. And they result in upregulation of the expression of PCOS in patients. And recombinant FSH, if you use, it is induced better ovulation induction. So the hirsutism and the hormonal profiles, if you give omega-3 fatty acid, the LH, the total testosterone, and all this improve, and you have increased SHBG levels are low in PCOS. Once you give omega-3 fatty acid, they all improved. And also it improves the inflammation and also decreases the insulin resistance. The nicotinic acid is known B3 vitamin, which also helps in reducing the free fatty acids and the triglycerides. Niacin acid inhibits the triglyceride hydrolysis. So nicotinic acid can improve lipid profile by lowering the LDL-C particles, the nanoparticles of LDL, and it also increases the HDL levels. So the HDL are cardioprotective. So lifestyle, of course, all of us know this is the main number one. Without this, the others, whether you give statins, whether you give omega-3 fatty acids, D-carotene, myoinositol, whatever you give, they do not act unless you stress upon the woman that she has to have physical activity. You tell them without physical activity, there's a lot of storage of fat in the abdomen and in all the muscles. And this fat is a good receptor. The androgen receptors increases in the adipose tissue. Once there is more of androgens, which are live, they're all stored, they're always sleeping in the adipose tissue. So if she does not have any exercise, the androgens are released slowly from the fatty tissue. And then she becomes gradually, from a female, she turns into a male. So, and this muscle fat will only be reduced by physical activity. Thereby, with physical activity, they will lose their androgens. Once you lose androgens, all the others gradually is put into place, and even your medication which you give, myoinositols, all of them have a better effect once the woman has physical activity and diet. For diet, all of you know, she should not starve. Eat more, but eat healthy food, not junk food. Every 3 hours, let her have healthy food. Have lots of vegetables, lots of nuts, flax seeds, peanuts, lot of curds. And these are things, lots of vegetables, dals, nuts. All these you should have. Less of carbohydrates, less of fat, and less of fizzy drinks, less of junk food, and your drinks, Coke, etc. And if they can achieve, if they're obese, if they achieve, because of this, they will definitely achieve weight loss. So you have to tell them why they should lose weight. You tell them if you don't lose weight, all your androgens receptors will increase in the fat and you'll become a male. If they want to become a male, they lose their voice, they become a male voice, they have a lot of beard, and they'll have to start shaving, they'll become bald. So you tell that to a young girl, she's very, then she says, no madam, I'll do what you say, and then they start doing the exercise. Till you impress upon them what happens if they don't do exercise, they will not, they'll think madam is mad, why is she telling about exercise? Why can't she just, she's a doctor, she has to give me medication. Why is she asking me to run? And they have to do it. The medication can stop after some time, but not her physical activity, because this is a lifelong disorder, and you impress upon them later on, if again they stop their exercise, they are more prone for CADs. and carcinomas. So reduction in weight loss of 5 to 10%, ovulation occurs, and more than 10% pregnancy occurs without ovulation induction or without your IVF ICSI. Sorry for the infertility specialists, but it does help. Even in infertility, if you're doing IVF, if they are reduced in weight 5 to 10%, they get a better success. So weight loss is very, very important, and lifestyle modification is important. Let them just do sport jogging. It's COVID, I can't go to a gym. Okay, stand up in your room. You know, I'd have a very small house, doesn't matter. You stand wherever you're standing, you can skip. You act as if you're skipping. You don't even need to buy a skipping rope. So dietary risk, eat more, eat every 3 hours, eat healthy food. And then of course, pharmacotherapy, you give your probiotics, prebiotics, you give your myoinositols, dechiroinositols, all of them reduce inflammatory factors, dyslipidemia, and also insulin resistance. With time, most of them reduce. One of my patients, within 6 months of this, just eating more healthy food and half an hour of exercise, she lost 20 kg. I myself was surprised. So very low calorie diet resulting in rapid, I know I want to do keto diet, I want to do vegan diet. All these fads they're fads. You do not encourage them. Let them eat what they're eating every day in small quantities. Instead of eating 2 cups of rice, ask them to eat 1 cup of rice. Reduce the quantity of carbs and fat. Increase the quantity of vegetables. So in a plate, 1/4 of the plate only is carbs. 3/4 of the plate is proteins, uh, dairy products, vegetables, legumes, nuts, fruits, milk product. And metformin, if she is insulin resistant, she has, you can give them insulin, metformin 850 milligram twice. You can start with 500 twice and increase it if she is okay with it. Because most of them, once you ask them not to have rice, they even reduce the amount of vegetables and fruits, and they say, I've become very weak, I cannot stand, I'm feeling giddy. So when they reduce rice, in India, we eat, rice is a staple food. And mentally we say, if we don't eat rice, we become weak. I said, yes, if you don't eat rice, you become weak because you're not increasing your vegetables and proteins. You eat more, you eat about half a cup of nuts, peanuts. If you can't afford almonds, take walnuts, take peanuts. Peanuts is a very good source of protein and very cheap. And very obese, of course, you have to maybe grow. If their BMI is more than 32, she has to have anti-obesity drugs. And maybe some people grossly obese, they may have undergo bariatric surgery. So myoinositol, all of us are using dechiroinositol. Though there is no Cochrane data, but we have seen that it definitely improves the insulin resistance. And if you start it early on, it reduces dyslipidemia, and it also decreases the inflammatory response, which are all the background features of PCOS. So what here I want to tell you is dyslipidemia is one of the early features. We never gave much importance. We never did a lipid profile for all these women with PCOS. Now with increasing awareness, you do a lipid profile, fasting. If the triglycerides, how much should it be high? Cholesterol, if it is more than 12 milligram, more than the normal, it is abnormal. And triglycerides, LDL 6 milligrams more, it is abnormal. And HDL, if it is LDL more than 12 milligram, then above the normal is abnormal. HDL, if it is less than 6 milligram, it's abnormal. So, and triglycerides, if they're abnormal, you do a postprandial triglyceride level. If it is high, they are very, very high risk for CAD. This is the most important take-home point I want to tell you. So there is increased plasmalogen biosynthesis or serum levels, especially effective in improving the hyperlipidemics and metformin. Metabolic syndrome. So screening for cardiovascular, I told you earlier on, only if they are obese, please do a lipid profile. Obesity, and if they have no physical activity, if they have smoking, family history of diabetes, or if they have dyslipidemia in the family, the mother says I have a lot of cholesterol, fatty livers, everybody, they get a scan done and say I have fatty liver, grade 1 fatty liver, please do your LFTs, please do the triglycerides. If they have hypertension, impaired GTT, of course you do the HbA1c, all pre-diabetic, anybody with 5.8 HbA1c, they are all pre-diabetic. They don't need treatment except lifestyle changes. And these are the women who are more prone to have dyslipidemia and increased insulin resistance. So for them, you tell her you are pre-diabetic. Though you're not a diabetic, you don't need treatment, but you will have all the complications which a diabetic lady will have. So take care so you don't become worse, or you don't end up taking insulin and metformin. So late reproductive is very, very important, where you have to do your lipid profile, not only the fasting, but also 2 hours post-lunch. And as age increases, insulin resistance increases, abdominal, you have midlife waist circumference increases. So dyslipidemia increases, metabolic abnormalities increase, waist circumference increases, triglyceride levels increase, and all these are high risk for strokes and cardiac CAD. So we have seen our own colleagues, gynecologists, who have had at the age of 40, 42, 45, having heart attacks. I have never seen when my colleagues, when we were 40, 45, no, we said, yeah, she has estrogen, so she won't have a stroke. But today, we are seeing young girls, I call them girls, yeah, my assistants, my students, 40, at the age of 40, 35, they're having strokes. And my 32-year-old patient of mine, she had a stroke and weakness of the left hand and limb. She has to limp. Dyslipidemia. She is lean, so she thought she has no PCO, though she had irregular periods once in 3 months, 4 months. They put her on, without doing the insulin resistance, she was on OC pills. 1 cycle of OC pill, 2nd cycle, she had a stroke. So be very careful when you're prescribing OC pills in these PCOS girls. Please do the HbA1c. If you think she has pre-diabetic, don't put her on OC pills. So insulin resistance, hyperinsulinemia, hyperandrogenism, very, very important. The hallmark of PCOD syndrome. Metabolic syndrome, you must have hyperandrogenism. They can lead to obesity, and obesity, dyslipidemia, hypertension, glucose intolerance. So you have sympathetic nervous system in dysfunction, inflammation, increased oxidative stress. So you have to give prebiotics, probiotics, reduce your inflammatory, check for inflammatory markers, fibrinolysis imbalance, vitamin D deficiency, and mood disorders, gut. That's why we give all of them, we give probiotic, prebiotic, because the gut microbiota also is disturbed with dyslipidemia. Epigenetic alterations, premature atherosclerosis leading to strokes, endothelial dysfunction, coronary artery dysfunction, non-alcoholic fatty disease. And once they have non-alcoholic enlarged liver, these girls in their 30s, I have so many of them who are in their 32, 34, who have become diabetic, and before become pre-diabetic and diabetic, they have enlarged fatty liver. And once you do the lipid metabolism and LFT, it's abnormal. They say, what is there? What happens if I have fatty liver? You ask them to do a diet and exercise. They don't want to do it. And then they end up having strokes. Young girls, 32, 35. Of late, I have seen this only in the past 10 years. Before, earlier to 10 years, I have never seen young girls and young women having strokes. But now, in a month, at least one. So the myoinositols, though there is no Cochrane data available, we have got a lot of studies, and personally also all of you must have used, and all of you know that it definitely helps, and it does help in lowering dyslipidemia, and the inflammatory response also it lowers. So it reduces whatever, even if it's a 5-10% help, it is good enough. But these do not act unless she does the lifestyle modification. You give her any amount of myoinositols, if she just sits in her room whole day long, no exercise, no the control on the diet, she still wants to have her burgers, pizzas, double cheese crust pizza, and only she drinks only Coke, fine. She's at a loss. You ask her, choice is hers. She wants to be healthy, she doesn't want to be healthy. That's her choice is hers. Thank you. And any questions? Yes.
So much, ma'am, for giving all this information regarding dyslipidemia in PCOS. So let me check if we have any questions. So, ma'am, one of the questions related to diet, how much there is impact of non-vegetarian diet on dyslipidemia?
Yeah. See, we know free fatty acids are found in fish oil. So if they eat fish, it's good. But then they should
Yes.
not deep fry anything. Red meat out. Any other chicken and fish, of course, seafood they can have, but don't use a lot of oil. They said, I'm eating fish, but still I'm putting on weight. You ask him how much of
Yes.
oil you use. No deep fry. You put very little. So I don't ask them how much oil. They say very little. So their little might be more of mine. So in 1 month, what is their oil consumption in their home? This one patient said there are only 3 people in the house. They use 15 liters of oil per month. I said, are you drinking oil? And all of them have dyslipidemia. So most of it is because of these oils they use. They say, I'm not eating, but their food is full of fat, fatty food. So red meat, they have to avoid. Oils, yes. 1 teaspoon of ghee per day is very good. 1 teaspoon oil per day, per person. 1 to 2 teaspoons. That's what the cardiologists advise. If you are the 3 persons, so two teaspoons of oil per head. So 3 twos are 5 to 6 teaspoons per day. Whatever you want to cook, you cook in that 4 to 5 teaspoons of oil. You can make biryani, you can make whatever you want under the sun. But the oil consumption, diet is protein diet, eating amount, like 1 fistful of peanuts are good. If you eat half, 1/4 kg, it's bad. But a fistful, 4 or 5 almonds, 3 walnuts. Walnuts reduce dyslipidemia. So please ask them to have walnuts. It is very flax seeds. Flax seeds are very cheap. That reduces the fats, dyslipidemia. It reduces the free fatty acids. If they can't, because we can't take fish every day, we are prescribed omega-3 fatty acid. Salmon fish, how many of us can get salmon fish here? So salmon fish is the one which contains a lot of omega-3 fatty acids naturally. But all of us can't do that every day. So we have this vegetarian omega-3 fatty acids also are available today. You see for the green dot, you can give them omega-3 fatty acids, plant-based, and most of them are protein-based omega-3 fatty acids. They lower the free fatty acids. So no oil.
The second, yes, ma'am. What?
Second question you said?
Ma'am, you were saying something regarding no oil?
No oil, yeah. Reduce the oil. That's all in your diet.
The second question is regarding the exercise. Like many of the patients will go for first 3-5 days, then we will go up to 1 month. Then after the profile gets normal, they go back to those high rich diet foods.
Yes.
So there is chance of recurrence of the dyslipidemia.
Definitely. The first sentence I told you is PCOS is a lifelong disorder. You can only suppress it. There is no cure. You have to impress it upon them. They are only bothered. Now when the young girl comes to you, she's only bothered about her acne and her looks. But when the reproductive age group, the girl comes, she's only bothered about her fertility. So you tell them, yes, today you're bothered about fertility, but your life doesn't end with your having a baby. You have to be there alive and healthy to look after your child. So to be healthy, continue this process. So it all depends on your counseling. And if they come back again, you tell them, see, you have to, it's your choice. Healthy life, you want to stay healthy for your child, you want to live for 75, 70 years without a problem. We don't know how much our life span is, but to stay healthy, I'm not saying it will increase your lifespan, But to stay healthy, to stay active, you want to look after your child. See, this girl, she, of course, she had a child later on, the one who has had a stroke, but she is unable to carry a child. She's unable to take her child to the school. So if you want to be healthy, to do so many things for your children or for your own self, leave alone the child,
Yes.
for your own self. She can't drive a car, she can't drive a cycle, she can't swim. So if you want to do something for your own self, and then when she wants to go out travel, she needs a companion. So if you want to be healthy, please have a healthy lifestyle. However long you live, be healthy, active, fine, be happy. That's it. So you have to just counseling. It all depends how you counsel, and you tell them whenever there is excessive fat, the male hormones, the androgens, they won't know if you tell them androgens. Tell them the male hormones get deposited. They sleep. They love the fat and sleep there, and they will only get excreted, thrown out of your body if you do your muscles contract and relax. How will your muscles contract and relax? Only when you do exercise. So running, walking, brisk walking. They say I'm working, I'm doing all the household work. Household work does not come under the exercise. Because you do for 10 minutes. If you, I say I sweep my home, she said. But how long does she do? Half an hour, and she doesn't. If you're doing it as an exercise, you have to pull in your tummy, bend, don't bend your knees when you bend down. Do it, sweep like as if you're doing an exercise. If you do that for more than half an hour, yeah, it becomes an exercise. And they want to finish their chores quickly, so they bend their knees and you bend down to sweep. So that's not exercise. You do the breathing in and out when you're doing sweeping, then it becomes a little exercise. But you do it continuously for more than 30 minutes, 40 minutes. Exercises continuously for, I'm walking from this room to that room. That's only 5-10 minutes, and then you sit and then you talk on your phone. That's not, you have to do continuously for 40 minutes, not break. Do it at least alternate day, if not daily, alternate day. You don't have to join the gym at all. Do it alternate day. If you can't do it, you don't have time. I say, why don't you have time for yourself? When you're brushing, you do jogging. You do jogging and you brush your teeth. 5-10 minutes, your jogging is done. Same as if she's a housewife, she's there waiting for the milk to boil. 10 minutes, let her do spot jogging in front of in the kitchen. So while she's doing her work, she can do her exercise. So it's just how you counsel your patient is very important. All the girls will tell, I'm working from 7 to 7. I don't have time. But how do you go to work? Take the cab. I said, okay, ask the cab to go two stops forward, and you walk down there and get into the cab. So that again is your exercise. You don't have to spend extra time. And climb up. Don't use your lift in your office. And the office food, try to eat food which is not oily. They have parties and everybody's birthday, cakes, samosas. These you have to avoid. Cokes. All these IT offices, IT girls, they're night duties.
Night shift jobs.
They say, I come back at 3 a.m. I can't do anything, then I sleep. I said, no, you come back at 3 a.m., you drink something. Have buttermilk or have a cup of curd, which is probiotic, and then go to sleep. If you sleep on an empty stomach, you get up, you feel very hungry, whatever is there, you start eating and you eat more. So you have something, you have a buttermilk, or you have curd, or you have a fruit, or you have some almonds. Then go to sleep. When you get up, you won't feel so hungry, so you eat healthy food. So you have a lot of craving when you're sleeping. You get up on a very empty stomach, you have a lot of craving. Whatever is there in the fridge, you tend to eat. So that's how you have to plan. And you must be very motivated to be healthy. I'm not saying lose weight. I say be healthy for your own self, for your own happiness, for your own health.
Mental fitness is also necessary.
Very important. Meditation. Try to be happy. Whatever is there. See, we can't alter certain things in life.
Yes.
Accept, and if you can find a solution, find a solution. Don't think of the problem, find a solution. For every problem, there is a solution, but the price you pay for the solution may be high. Now she's infertile, she can't conceive. So the option is there. Adoption, final option is always 100%. You can treat for infertility. But then you have to, the price paying is high because everybody mentally is not fit to adopt.
Absolutely,
We are not geared up for adoption. So that's why I say every problem has a solution. Only thing we have to make up our mind to accept the solution. But there in between adoption and infertility treatment, there are many phases. So you do it, you will succeed. Unless you don't have tubes or uterus, maybe you have to think of adoption. I have one IVF patient, she had 16 IVF cycles, 16 cycles.
Oh.
16th cycle.
She
On the 16th cycle, she conceived. So it's just her motivation, that's all.
some motivation, yes.
So every problem has a solution. Simple. You have to think
For
that
giving
way.
this
I mean,
great,
a mindset.
yeah.
So I tell the women, see, teach your children this. So when the woman comes, I tell it's not only for you, but also for your kids. So
Yes,
my kid is worried she didn't get a seat in MBBS. I said, fine, if she doesn't get an MBBS, maybe she'll get in veterinary, she'll become a veterinary doctor, or she can become a dentist. It's okay. All are good enough. But our mentality, we are not bringing up our children that way. So there is a lot of, and there are so many. So let her be an artist, let her be whatever she wants. Let her be happy, finally. Happiness is all that matters. In whatever they want to do, let them be happy.
Good advices, ma'am. Yeah. Ma'am, one question from my side that are there any increase in the PCOS cases after COVID?
After COVID, we have a lot of menstrual disturbances, menstrual irregularities, and because I don't know whether it is COVID or because they're sitting at home, nothing to do, we are eating well,
Yes.
trying different dishes. The men are also cooking. So even in my we're all trying on YouTube different types of dishes. So that's maybe one of the reasons you put on weight. But I haven't, as such, PCOS, menstrual irregularities, yes, increased by 50%. Maybe underlying weight gain or whatever. We have to, unless PCOS is not only scan, you have to do your blood investigations to tell, confirm PCOS. LH, AMH, LH has to be increased.
And which age group is at a higher risk in PCOS after COVID?
After COVID, all those women who have irregular activity, regular menstrual cycle, amenorrhea, those who have anovulation, they're at more risk for becoming Pcos syndrome. The adolescents, middle age, the perimenopausal age group, they are having more of postmenopausal bleeding and cancers. But in adolescent and reproductive age, they are becoming PCOS and a lot of menstrual irregularities.
So thank you, ma'am, for giving all the
early miscarriages. All these women
early miscarriages,
early miscarriages because of COVID. They need not get COVID. Even without the infection, we have seen an increase in the miscarriages. Why, I don't know. Explanations, I don't know. But we have seen a lot of miscarriages with no reason. It has occurred during the second phase was a lot, first and second wave. We had third wave was not so much. Second wave, we had a lot of miscarriages.
I think so that lifestyle change has been
very important. See, when our grandparents, parents, they were walking, they were, and now we have everything remote controlled or for everything.
Yes.
We used to get up and change the TV channels. Now we have a remote for everything. Even my granddaughter doesn't want to walk. So they all want to play. They all want an iPad, they all want an iPhone. And they want to, they don't want, even when the friends come, all of them sit and play games on the computer. They don't want to run and play. Even 7 years, 8 years, they don't want. When we were children, we were always running on the road. Now nobody wants to play. We're only playing game 7 stones or whatever. All the time running. Nobody wants to walk also. We used to walk to school. But of course, it's dangerous now anyways. But even schools have no compounds. They don't have a lot of space to encourage games.
Yes.
Few schools only encourage games and drill. We used to have 4 periods in a week for games and drill, PT.
Education training, yeah,
Now
PT
we
training.
don't have, nobody. And then those days didn't have mixies. We used to use the grinder, silbatti.
Mm.
Then now nobody, all of us only mixie, so we don't get up.
Everything is automated now.
Everything is automated, microwave, gas. Even to open the door, you have your automatic. Even to open your garage door, you have a remote control.
Yes.
So where are we walking? We are not walking. So that's why at least do some exercise. Just stand and do jogging in one place, I say. That is enough. 30 minutes spot jogging. You can't do anything else, do that. Good. Every day you do half an hour, you're fine, fit. Simple jogging, stand in one place, spot jogging. Don't have to run on the go to the, it's COVID, I can't go to the garden to walk. Don't walk. Stand in your home and I can't get out of my room. Okay, stay in your room, run. 5 you can stand in your room. Yes, then do jogging. You have space to stand in your room, enough. They say I don't have enough space to walk. If you have enough space to stand, you can do your exercise.
Yes, yes.
So it's all.
Thank you, ma'am.
You have to. Counseling is very important in these girls and women.
And that is lacking at these days.
And then your doctor, nobody is spending more because of COVID. You're not spending more than 10-15 minutes. You can't tell all this in 10 minutes time. But once COVID is gone, the fear is gone. Maybe if you go back to previous, taking a good history, examining, spending more time, minimum half an hour with the patient, then you can.
Yes.
If you talk to them, convince them, they do it. They may do it for 6 months, and once they become pregnant, have a child, again they forget. But then say, madam told me I didn't do, I'll do it again now. They'll themselves will come back and tell you.
Thank you, ma'am, for
Thank you.
Giving all these great advices, and hope the delegates have
I hope
got lots of information.
Thank all the delegates for using up their precious evening time. Thank you very much for listening.
Thank you, ma'am.
And I hope.
And we would like to have more new sessions with you on.
If you gained something, the dyslipidemia, I myself was shocked to know it is so important.
Yes, ma'am. Like you mentioned, that like after 30s, this dyslipidemia has been increased.
Common. You have to do it. You have to do your lipid profile. And fasting and postprandial. I once again thank Shield Connect for giving me this opportunity. Wish you all the best, and thank Pawan once again.
Thank you, ma'am.
Thank you so much. Can I sign off?
Yes, ma'am. Bye, ma'am.
Yes, ma'am. Yeah, you can. Thank you.